So I'm going to discuss Federico's case, and I don't really have new data to present to you here, but I thought that this case was really interesting, so I wanted to point out a few points. So this patient previously had a trab with mitomycin and then a subsequent shunt, and then had a right hypertropia. But the thing that's really interesting is that right hyper was better in down gaze. So if you look at these deviations, you've got 14 in primary, 20 in up, but only 4 in down. And that's a little counterintuitive. If you truly have a scarred or tight superior rectus muscle, then you really should be increasing in down gaze. So what could be going on here? So I just listed a couple things that might be happening. You could have a mass effect from the shunt. You could have restriction or tightness of a scarred superior rectus, weakness of the inferior rectus, or true overaction of the superior rectus. And we're going to ignore the superior oblique for just a moment. Let's go back. So if it's a mass effect, you would expect the eye to be hypotropic, not hypertropic, because you're shunt superior. Deviation, again, should be worse on up gaze. However, again, we're seeing the opposite here. So restriction of the superior rectus, again, if your superior rectus is really super tight or just scarred, then the eye is tethered up. Again, your deviation should be increasing on down gaze. If the inferior rectus is weak, can't pull the eye down, deviation increases on down gaze, and there's been no previous surgical manipulation inferiorly. So really overaction of the superior rectus muscle is the only viable explanation that would cause the deviation to truly increase in up gaze, which doesn't make a lot of sense. So he said forced ductions were free or mostly free, so conceivably not due to restriction. So it seems like the muscle's truly overacting in the field of action. So how can that happen? So there's the so-called Jampolsky Syndrome, which is overaction or contraction of the superior rectus, characterized by a hypertrophy that increases in up gaze, decreases in down gaze. There's a positive head tilt test, relatively free forced ductions. Jampolsky described this, I think, way back in the 60s, but I think wrote about it mostly in the 80s. And so generally associated with a superior oblique palsy and chronic contracture of the superior rectus muscle on the ipsilateral side. My understanding of this has been influenced by Bert Kushner's writing, and he had a paper there in archives that you can see about mechanisms of extraocular muscle overaction. So what could be really happening here? So again, the Jampolsky syndrome, ipsilateral superior oblique palsy. I'm going to skip over to that second topic now, which is the muscle toxicity due to injection and chemical exposure. So most of us have heard with retrobulbar injection, accidentally injecting the inferior rectus most commonly, and having that muscle initially paralyzed, but then remodeling and becoming tight due to changes in the sarcomere. But it's not just that the muscle's truly only tight and restrictive, it's that it truly overacts by that sarcomere remodeling. And so in that circumstance, you really have to supramaximally recess that muscle to correct your deviation. So treatment for that condition, supramaximal recession of the muscle. So would have doing an additional surgical approach to that initial superior rectus muscle recession made a difference? Well, the truth of the matter is we don't know, and all of us have had these cases. It may have shown us something if the head tilt test was positive. There could have been something associated with him freeing that superior oblique. So it's hard to know what role that played in there. And it's unknown if initially the superior rectus was supramaximally recessed, if all the inferior rectus surgery would have been necessary. So again, hard to know exactly how to address these cases, and certainly very scary to supramaximally recess the muscle. Interesting to me that the patient had a trab first and had the mitomycin and then had multiple needlings. Could you be needling the superior rectus at the time that you're needling the bleb, and that you're potentially inducing the sarcomere reformation by multiple needlings? Hard to know, but very interesting case.